Okay, so our MEC Minute for the month of January 2018 is going to be acute non-traumatic abdominal pain, or in other words, abdominal pain not related to injury. Why are we talking about this? Well, for EMS providers as well as for those of us who work in the emergency department, abdominal pain is a frequent reason for patient calling, patient being evaluated by EMS, and frequently for transportation to the emergency department. When we deal with abdominal pain, we have to often think, just like we do for other patient conditions, is this patient sick or are they not really that sick? In other words, is the pain something that represents a really bad condition or a bad problem, which is very uncomfortable, or a problem that's uncomfortable but in itself is not dangerous? And, excuse me. And sometimes you just can't tell. So we have to think about it with our patients. Is this pain really bad, but not a risk, or is it really bad and a risk to the patient's health and well-being? We have to always think about the bad things, and we'll talk about some of the dangerous conditions toward the end of this talk. Is this a problem that represents an immediate threat to the patient's health? And we always have to think about the bad things first. So common problems that might cause abdominal pain, and this is not an all-inclusive list, but it's common for things that you may see. Gastroenteritis, meaning nausea, vomiting, diarrhea related to a virus, sometimes related to a bacterial problem like Salmonella or C. diff. But it has a lot of GI symptoms, and abdominal pain can be a component of that. Pancreatitis we see out there, sometimes it's acute, occasionally it's chronic. We're more likely to see acute pancreatitis than chronic, but pancreatitis or inflammation of the pancreas gland is a fairly common condition. Bowel obstruction is a cause of abdominal pain. Typically, it's related to previous surgery, but sometimes it's not. Acute cholecystitis or acute inflammation of the gallbladder is a common cause for EMS being called. Sometimes patients can have what we call biliary colic, where the gallbladder intermittently gives the patient symptoms because there may be a problem with some gallstones, but they haven't become severe enough where it's ongoing constant pain. We think about acute appendicitis. We'll see that in children and young adults, but you could still be in your 60s, 70s, or 80s and develop acute appendicitis. Kidney stones are a common condition that we see more often in the summer than the wintertime, but you may still see them in the wintertime. Sometimes urinary tract infections or urinary tract infections that progress to pyelonephritis or kidney infection can be a cause of abdominal pain. Can also cause nausea and vomiting with associated fever, and the patients can become quite dehydrated. Always think about pregnancy and its complications. When you see a female patient with abdominal pain, for those of us that practice in the emergency department, our saying is every female of childbearing age is pregnant until we prove they're not, no matter what the patients might tell us. I think about ovarian cyst, ovarian torsion. Those conditions can have symptoms that are very similar to each other, and sometimes we can't tell if it's an ovarian cyst or if it's a torced or twisted ovary unless we send the patient to ultrasound for an ultrasound. Pelvic inflammatory disease related to sexually transmitted diseases is also a condition that can cause significant abdominal pain with associated fever, and the patient can look quite toxic and quite ill from PID. Always think about umbilical or inguinal hernias, particularly if the patient has a bowel obstruction. For the elderly, the most common cause of a bowel obstruction is a inguinal hernia, particularly in men. So when a patient comes in with a bowel obstruction, we always check the groin to see if there's any evidence of an inguinal hernia. Acute diverticulitis is also a condition that you might see out there. Diverticuli are little outpouchings of the colon that we develop as we age, kind of like wrinkles. So having diverticuli is not abnormal, but sometimes those diverticuli can become infected, and that's called diverticulitis. The most common location for diverticulitis is the left lower abdomen in the area of the sigmoid colon, which is the last part of the colon before the rectum. So if you have a patient with pain and tenderness in that area, particularly if it's progressed over the past couple of days, diverticulitis is a consideration. Inflammatory bowel disease is a problem. Sometimes it's related to Crohn's disease, sometimes to ulcerative colitis. So if a patient has history of abdominal pain and history of inflammatory bowel disease, you have to think about the complications of that, which could be bowel obstruction, could be perforation or abscess formation. There's also something out there that we call cyclic vomiting. We kind of mix that and co-use it with another condition called cannabis hyperemesis syndrome. Cyclic vomiting is kind of like migraine headaches. Patients can have episode of discomfort, nausea, and vomiting and pain. Cannabis hyperemesis syndrome has similar symptoms, although it's associated with heavy and regular use of marijuana, and these patients will continue to have their symptoms as long as they continue to use marijuana. So you may see more and more of that out there. I've always wondered what the frequency of cannabis hyperemesis syndrome is in states like Colorado now that marijuana has been made legal in those areas. We should soon find out what's going to happen to Ohio with legalized marijuana on the horizon. So if you look at the abdomen, you can kind of have some estimate of the cause of the pain based upon the location of the pain. So if the patient has pain in the right upper quadrant, we can think about things like gallstones, pancreatitis, or stomach ulcers. If it's central upper abdomen, think about stomach ulcers again, any cause of heartburn or reflux disease. Pancreatitis and gallstones can give you pain in that area. And sometimes patients can have gallstones that then result in pancreatitis, and we'll talk about that in a moment. Hernias in the upper abdomen is a concern, and one thing that we'll talk about later, but it's not on this diagram, is epigastric pain, particularly in an older patient or a patient with risk factors for heart disease. Think about, could this be a heart attack or MI? So these patients may warrant an electrocardiogram based upon their symptoms. Patient with left upper quadrant pain could have stomach ulcers, duodenal ulcers. They could still have some problems with biliary colic or pain coming from the gallbladder, but that's unusual. Pancreatitis is also possible in this area. If you're talking about the right flank and the left flank as well, it could be related to kidney stones, urine infection, or pyelonephritis, meaning infection of the kidneys, not just the uncomplicated bladder infection. Constipation can do it, and various hernias can give it as well. In the central abdomen, think about pancreatitis, think about early appendicitis. Appendicitis tends to start in the epigastric area and then migrate to the right lower abdomen as the disease progresses. Stomach ulcers and inflammatory bowel disease can do it, as well as umbilical hernias and small bowel, inflammatory disease of the small bowel. In the left flank, think again about kidney stones and diverticular disease, as well as constipation. Inflammatory bowel disease can happen in that area, particularly if the patient has Crohn's disease or ulcerative colitis. In the right lower abdomen, you think about appendicitis. Again, constipation's a problem. Pelvic pain, either acute or chronic, can cause right-sided pain. Groin pain from an inguinal hernia can also be in this area. In the central lower abdomen, think about appendicitis, diverticular disease, urine infection, particularly a bladder infection. Other causes have been pelvic pain, such as endometriosis or inflammation of the uterus, any problem related to pregnancy, and also think about inflammatory bowel disease in this area. You can have some symptoms related to diverticular disease in the suprapubic area, but it's usually more in the left lower abdomen. And then finally, in the left lower abdomen, think about diverticular disease, pelvic pain, again, female origin, or it could be due to male origin as well if they have like prostatitis or some other issue going on in the pelvis. And then think about inguinal hernias on the left side as well. So thinking more about some relatively benign conditions, and I use the word benign, meaning that, yes, they're uncomfortable, but generally we can treat them if we identify them promptly. The first one to talk about is acute appendicitis. Typically, it's in younger to middle-aged people. It typically has gradual symptoms over 12 to 24 hours. Initial symptoms are pain in the area of the umbilicus or belly button, and that's because when the GI tract is irritated, the bowel is irritated. It's really kind of based on the nerve supply to the area, it gives you pain in the belly button or umbilical area. And these patients can also then develop nausea, vomiting, and loss of appetite. Later on, as the symptoms progress and as the inflammation in the appendix starts to irritate the abdominal wall, the pain can localize in the right lower abdomen, which is where the appendix is, and they can develop tenderness in that area. So when the patient develops early pain in the umbilical area, it's not that the appendix is in that area, it's just that the gut and its nerve supply gives you this nonspecific central discomfort. And you don't get the localizing pain in the right lower abdomen until the inflammation is severe enough that the lining of the abdominal wall is irritated and inflamed by the infectious process. With these patients, if you examine their belly, they'll have guarding in the right lower abdomen, meaning if you push the area, it hurts. They'll stiffen up to resist your pressure. They may actually push your hand away. They may also have rebound, meaning if you push your hand down and hold it for a second and then quickly, abruptly let go, it aggravates the pain as well. You also should be aware of something called a retrocecal appendix. That's where the appendix, instead of being in the front part of the cecum, or the first part of the large bowel, it actually is tucked behind the first part of the colon, and people can have really non-specific symptoms in that area. It could be an aggravating low back pain. It could mimic a kidney stone, and sometimes it's a very difficult diagnosis to make. But now that we have CT imaging as part of a routine evaluation of abdominal pain, it's less common that we miss a retrocecal appendicitis, whereas 20 or 30 years ago, we would commonly miss retrocecal appendicitis until symptoms became quite severe. Another condition to think about is acute bowel obstruction. Risk factors include previous abdominal surgery or inguinal hernia. So a bowel obstruction is anything that causes a mechanical obstruction to normal peristalsis in the bowel, normal movement of bowel contents from the stomach through to the rectum. So it could be a twisted bowel, it could be adhesions or tough bands within the abdominal cavity that cause obstruction, or it could be something as simple as an inguinal hernia where the bowel is trapped in the hernia and it just can't move things along, so you develop symptoms of a bowel obstruction. Symptoms generally have to do with pain. It can be localized or generalized depending on how severe the obstruction is. Patients can have associated nausea and vomiting. They may have loss of appetite. And if things go far enough along, they'll have abdominal distension and swelling, so that when you look at the belly, it's quite distended, and if you tap on it, it almost sounds like a drum. So from an exam perspective, you'll see abdominal swelling and distension on most patients. If you listen to the bowel sounds, they will seem diminished. You'll notice that there's tympany, meaning if you percuss or tap on the belly, it'll sound like a drum. And if you have a thin patient with significant bowel obstruction, sometimes you can actually see the dilated loops of bowel through the wall. It just kind of makes it look like you can see the individual markings of the bowel. It's not very common anymore, but when you have a thinner patient, you can see it. For these patients, we'll treat them with IV access. Make sure to keep them NPO. We should not be giving them anything to eat or drink, because if they have bowel obstruction, it's going to aggravate their symptoms. And then use Zofran and fentanyl for symptom control as indicated. Acute pancreatitis we'll see out there. Common causes are alcohol. For most of us, alcohol is the most common cause of acute pancreatitis that we see in the emergency department. Some medications can cause pancreatitis. Gallstones can cause pancreatitis. We call that gallstone pancreatitis. So if you look at the bile duct that comes from the gallbladder down into the bowel duct passes through the pancreas. If a gallstone gets stuck in that bile duct within the pancreas, it'll put back pressure on the pancreas, causing gallstone pancreatitis. The treatment for that is removal of the gallbladder and removing the stone that's causing the obstruction. Sometimes they'll actually have gastroenterology do upper endoscopy, and they can thread a catheter through and pull the stone out. So patients sometimes, if they have really high elevated triglycerides, can develop acute pancreatitis. The triglycerides are so high it causes inflammation of the gland, and it gets inflamed and swollen. The treatment is management of acute pancreatitis and then medications to bring the triglyceride level down. And then there's some patients who develop what we call chronic pancreatitis, particularly in alcoholics, where they have repeated episodes of inflammation of the pancreas, and it just develops a chronic process which is ongoing and causes episodes of recurrent pain. Symptoms of pancreatitis would include epigastric abdominal pain. It could be pain that radiates into the back. Typically, the patients are uncomfortable and have nausea and vomiting. On exam, the patients generally look uncomfortable. They may have tachycardia. If their symptoms are severe enough, they may be hypotensive, and they would have epigastric and tenderness around the belly button area as well. The treatments for these patients is nothing by mouth, IV fluids, and then appropriate use of Zofran and fentanyl in the field as necessary for pain control. Acute cholecystitis or acute inflammation of the gallbladder is a common source of abdominal pain. Risk factors for this include female gender, previous pregnancies, family history, and obesity. Symptoms include right upper quadrant abdominal pain, abdominal bloating, a lot of belching and passing gas by rectum. They can have pain radiating to the area of the right scapula as well. On exam, these patients are often uncomfortable. They have nausea and vomiting, and they have right upper quadrant tenderness. You may notice a positive Murphy sign. A Murphy sign is if you take your fingers and gently push up under the right lower rib margin and have the patient take a deep breath. As they take a deep breath, the diaphragm pushes the gallbladder and liver down toward the fingers, and when your fingers come in contact with the gallbladder area, it causes pain, and the patient often winces or stops inhaling. If the gallbladder disease is severe enough, you can actually see evidence of fever and jaundice. Jaundice is because there's back pressure on the liver and it doesn't function well, so they do not metabolize the bile pigments appropriately, resulting in jaundice. And the fever comes with infection. That's called cholangitis. That is a very bad finding, and those patients need aggressive treatment with antibiotics, drainage procedures, and fluid resuscitation. For acute cholecystitis, our treatment is IV fluids and then again Zofran and fentanyl. Kidney stones you'll see out there, again, more common in the summer, but they seem to be happening year-round. Kidney stones, it's kind of a misnomer because kidney stones are not a problem when they're in the kidney. It's when they migrate from the kidney into the ureter, which is the tube that connects the kidney to the bladder. That's where they tend to cause problems. So risk factors for kidney stones include previous history. So if you've had one, you're likely to have another. Family history, so it tends to run in the family. Inadequate fluid intake, so if you take inadequate amount of fluids, then you may not be able to water down or remove those salts that can precipitate to cause stones in the kidneys. Bariatric surgery increases the risk for kidney stones because of increased uptake of certain materials that can cause kidney stones. High protein diet or calcium supplements can also result in kidney stones, as can gout. Gout can cause stones made out of uric acid, which is the chemical that causes gout. And then some medications can also cause kidney stones to form, particularly some of the diuretics. Symptoms of kidney stone generally are acute flank pain, one side or the other. Usually patients don't pass kidney stones on both sides at the same time. So if they're having right flank pain, you think about a right-sided kidney stone. And that pain may be intermittent. So the pain tends to occur as the stone is moving through the ureter. So if it's kind of fixed and not moving, the patient may not have much discomfort at that time. The pain can radiate into the testicle or the groin. The patient may notice some episodes of blood in their urine. Kidney stone patients usually have some degree of nausea, vomiting, and diaphoresis. They often cannot find a position of comfort. No matter what position they're in, it still hurts. If the kidney stone has an infection associated with it, the patient can be hypotensive and develop a fever. Those patients typically are pretty sick, and if they have fever, they need to be admitted, start on IV fluids, antibiotics, and generally have to go to the OR quickly for drainage. Treatment for us in the field is fluids and adequate medications for symptom control, which would again be Zofran and fentanyl. Hernias, we may see symptoms related to that. Hernias sometimes can be very uncomfortable but not immediately dangerous, and sometimes they are uncomfortable and need to be treated immediately by a surgeon in the operating room. So we can have different types of hernias of the abdomen. One is the umbilical hernia, or a hernia in the area of the belly button. There may be a ventral hernia, which is a hernia or a weakness in the abdominal wall somewhere other than the groin or the umbilical area. And then you can see inguinal hernias or hernias in the groin. The other thing that we try to determine is whether or not the hernia is incarcerated or not incarcerated. So an incarcerated hernia means that there's bowel trapped in the hernia and the bowel is now in jeopardy because blood supply is impaired. A lot of patients walk around with hernias and there's bowel within the hernia, but the bowel's not trapped. The bowel is getting an adequate blood supply, but it's always possible that the bowel can get pinched off. There's inadequate blood supply, and then we consider that an incarcerated hernia. If you look at this picture, The picture shows a belly button, which is swollen. That's with the bigger arrow. That's the umbilical hernia. But then there's redness around it. That suggests inflammation and that this is incarcerated. I'm willing to bet that if you touch that hernia, the patient would be very uncomfortable. The treatment for this is quick surgery in the operating room to reduce the hernia, repair the defect, and get the patient on the way to recovery. So typically symptoms for this would be swelling, pain and tenderness. If it's incarcerated, symptoms of a bowel obstruction. And if it's incarcerated, you would also see skin redness. The treatment is generally nothing to eat or drink until you know whether there's an incarceration. Treatment with IV fluids if you think the bowel is incarcerated. And then symptom control with Zofran and fentanyl in the field if it's clinically indicated. I can tell you a lot of the patients with hernias in the emergency department that we see, they do not have incarcerated hernias. We treat them with ibuprofen or something that's non-narcotic. Also think about gynecologic causes. So I've kind of thrown up a whole list of things to think about when you have a patient who's complaining of abdominal pain or a gynecologic complaint. So the things that I think are necessary for you to ask and document would be, when was the patient's last menstrual period? Is she using anything for contraception? Has she had a previous hysterectomy? Does the patient have a previous history of ectopic pregnancy? Because if you had one tubal pregnancy, you're increased risk for another. If the patient is pregnant, have they had an ultrasound yet? It's always nice to know if the patient's had an ultrasound that has confirmed an intrauterine pregnancy or a pregnancy in the right place. Does the patient have a history of ovarian cysts or endometriosis? Endometriosis is where you have tissue similar to what's inside the uterus, outside of the uterus, in places where it can cause bleeding and then irritation of the peritoneal cavity. That can be very uncomfortable. If your patient is complaining of gynecologic issues and is having vaginal bleeding, then how many pads or tampons have they used today or since this started? How long has it been going on? And then finally, if the patient's passed any tissue, particularly if they're pregnant, did you pass anything that looks like tissue? If so, where is it? Because we need to take it with us in the emergency department or to the emergency department. Things to also think about as part of gynecologic causes is, could this patient be having a miscarriage? Could they have an ovarian cyst or ovarian torsion? Ovarian torsion is where the ovary twists on its stalk, cutting off the blood supply. And if that torsion is not quickly identified and treated, which means surgery, then the patient's at risk to lose that ovary in a fashion similar to if you had a male patient with torsion of the testicle. And then always think about an ectopic pregnancy. So let's talk about some acute life-threatening conditions for which you always have to have a high level of suspicion. The first is abdominal aortic aneurysm. I think we all are aware of it. A lot of times we think about it. Risk factors include male gender, age over 60, a history of hypertension or hyperlipidemia, or a history of tobacco use. Symptoms typically are abdominal pain, sometimes mid-back pain, sometimes the patient has syncope, because there's rupture or leakage from the aneurysm. On exam, the patient may be hypotensive, they may be tachycardic, they may be diaphoretic. You may feel a pulsatile mass in the mid to upper abdomen. And if you listen with your stethoscope, you may hear an abdominal bruit or a shh, shh, shh sound with the patient's pulse. In over 30 years of practice, I've only heard a couple of abdominal bruits. I'm more likely to feel a pulsatile mass. The treatment for this is IV access, rapid, prompt transportation to the emergency department. Don't stay and play. We want to get this patient in the truck to the hospital, because if they have an abdominal aortic aneurysm that's leaking, they can die in minutes, and we need to get them imaged and, if necessary, in the intervention lab so they can have their aneurysm repaired or grafted. And then early notification of the receiving hospital so that we can clear the CT table. If necessary, call the the vascular surgeon or whoever's necessary to start working on this patient. Ectopic pregnancy is another condition you always have to think about in any female of childbearing age who has abdominal pain. In previous centuries, ectopic pregnancy was the second leading cause of maternal death, with childbirth being the greatest cause of death. So ectopic pregnancy patients, if it's undiagnosed and untreated, it can rupture and the patient can bleed to death very quickly. Every female of childbearing age is pregnant until proven otherwise. I'm willing to bet that at my hospital we have a couple pregnancies a week in patients who swear that they are not pregnant or couldn't possibly be pregnant. So we have to have the test result on the chart that says negative pregnancy test. Signs and symptoms can be vaginal bleeding, which is one of the most common symptoms of ectopic pregnancy. If the pregnancy has ruptured or is leaking, the patient could be hypotensive or tachycardic or have symptoms of orthostasis. So maybe they passed out or had a syncopal episode associated with abdominal pain. It could be a ruptured ectopic pregnancy. Abdominal tenderness is a concern or a symptom, as is shoulder pain. So if the patient has a ruptured ectopic, that blood can go up around the diaphragm area, which can give you pain in the area of the shoulder, and that's because of the way we develop as embryos. So the diaphragm muscle is actually innervated by the nerves to the shoulder area, so if it's irritated, we have symptoms of pain in the area of the shoulder. So how do we treat ectopics? First is a very high index of suspicion, IV access, keep the patient NPO, and get the patient to the hospital quickly. Bowel ischemia and dead gut. I've kind of linked two different conditions into one page. Bowel ischemia could be just an inadequate supply of blood to the portion of the bowel, resulting in bloody diarrhea. Dead gut is usually an embolic event where a blood clot goes or comes from somewhere, goes to one of the major arteries of the gut, abruptly cutting off the blood supply, and the bowel starts to die. So for bowel ischemia and dead gut, it could be embolics. So a patient could have atrial fibrillation or a piece of calcium that breaks loose. AFib can develop a clot which can break loose and go to the gut, just like it could go to the brain and cause a stroke. It could be a mechanical cause like twisting of the gut, or it could be a state of low flow. So a patient with CHF or who's been a victim of trauma with hypotension, they can develop some ischemic gut. Risk factors include low flow states like CHF and trauma. Vasculitis can sometimes do it. Previous GI surgery is associated with this. And then atrial fibrillation, where the patient can develop a clot within one of the atria. It breaks loose and goes to the gut, causing loss of blood supply to that area. Signs and symptoms for a patient with dead gut typically have pain that's disproportionate to your findings on exam. So the belly may look soft and flat. You may touch it, maybe a little bit of tender, but the patient is just screaming out in generalized abdominal pain. If you have a patient who's elderly, has high-risk features like atrial fibrillation, always think about dead gut and their risk for embolic disease. Patients may have bloody stool, so they could have rectal bleeding. And if you're talking about ischemic symptoms where you have what we call ischemic colitis, or a section of the colon doesn't have adequate blood supply, it's more likely left-sided than right-sided. But if you do happen to have a patient with ischemic colitis on the right side, it tends to have a worse outcome because it could be not just the colon that's involved, but portions of the small bowel as well. For us in the field, treatment is IV fluids. Fluid resuscitation is important, keeping the patient NPO, and symptom management with Zofran and fentanyl. The last thing I want to talk about regarding those bad things that cause abdominal pain is really not something that's an abdominal process at all. It's a myocardial infarction. So you have to think about an MI in patients who have epigastric discomfort or epigastric pain that radiates into the chest. They could be diaphoretic, dyspneic, they could have nausea and vomiting. So you have to have a high level of suspicion. When we see patients in the emergency department with epigastric or upper abdominal pain who has risk factors for cardiac disease, we always get a 12-lead electrocardiogram on them, and a couple times a year we do an EKG and it comes back positive for an MI. I have an EKG here from a number of years ago, and it's got that acute inferior ST elevation noted in AV or leads 3 and AVF. I kind of have a little red dashed line in there that gives you an idea of the baseline so you can see the elevation better. So this patient came in with abdominal symptoms. We got an EKG and it shows an acute inferior MI. Inferior MIs are typically the types of MI that give you GI symptoms because the lower part of the heart sits up against the diaphragm, which is right up against the upper abdominal area. Finally, I just want to cover one topic which has come up over the years. It seems to be less of an issue now than it's been in the past, and that's should we avoid administering pain medications to patients with abdominal pain. So in the past there's been discussion and concern, particularly by some old world ED docs, old world surgeons, that if we give them narcotics in the field, it's going to impair the abdominal exam and clinical decision making in the emergency department. So the question is, should we avoid giving pain meds to patients with abdominal pain? Well, I think the answer now is no, and I think that's very well established that studies have repeatedly shown that pre-hospital narcotics do not interfere with an ED workup. We will go in and see a patient, and first thing we do when we finish with the patient is we'll order pain medications, and we don't worry about whether or not the surgeon needs to do a better exam 2 hours down the road. We use fentanyl, which has a clinical effect for 20, maybe 30 minutes, 40 tops. So by the time you get the patients to the hospital, we get them on the gurney and we have a chance to do our exam. The fentanyl is worn off to a large extent. Plus, we become so reliant on laboratory work and CT imaging that we've almost become non-reliant on our physical exam. I hate to say that, but it's the truth. So, symptom management in the field is definitely not going to interfere with lab tests and results of a CT of the abdomen or ultrasound of the abdomen. So if you think the patient needs narcotics in the field, use them. So that's all I have for now. If you have any questions regarding this presentation, feel free to post them on Workplace. I have attached to the MEC Minute a fairly lengthy article, but I think it's got good information for your use. Thank you for your attention. I'll talk with you next month.